Geriatrics, Worldview, Expectations, and Ethics. Now that's quite a mouthful. But for several years, Ruth and I have tried to find a certain speaker that could combine all of these things. How you look at your patient or your client, how your patient or client looks at you. What are your expectations for the person you're going to be working with? What are their expectations, not just of what you're going to do for them, but of overall outcomes? How does this person look at the world? How does this person look at different types of medicine? One of it is, you probably know from hearing me before, my big interest is in minority health. And in fact, this time next week, we'll be staying with some friends in a pueblo in New Mexico. Their expectations of medical care, especially the grandmother, are totally different than most of the things that we think of. So, you know, we get, especially when we're at a health science center in a city like this, we get in a mold. There's a person with a problem. We can diagnose the problem. I know how to treat them. We'll do it, and everything will be fine. So then we get into something called compliance, a word I absolutely detest because it means doctor knows best. But then we have the word adherence, which means a mutually agreed upon course. And that's sort of where I'm coming from, with a background in public health. So I'm going to sit down up here and we're going to talk about some things. Okay. Does anyone have their own definition of worldview? Is this a new term? Is there someone in here that knows what we mean by worldview? Okay. Every culture, no matter how young or how old, has a worldview. And this is the way human societies look at reality, what things really are like, and how they look at the world. And this worldview consists of basic assumptions that may or not be accurate, but more or less coherent to the person. Everyone has his own outlook. One author identified worldview as their picture of the way things in actuality are, their concept of nature, of self, of society, and of medical care, and of dental care, and everything else. So everyone, every group, every one of us comes from a different culture probably, or a different mix of cultures, and our background all gives us something that makes us look at the world in a different way. And for health educators and practitioners to understand their patients and then in turn to reach those patients, you need to look at the person's background. Now, you've all heard all these things. You live in South Texas, you practice here. You've all heard these things, but we'd like to put it in a little different perspective. Someone once wrote, now this was a Native American, he was writing about culture, and you know, our family heritage, no matter what it is, goes back many, many thousands of years, and we're all a mixture of what our ancestors were. And he says, all cultures ask the same question: where did we come from? How did the world begin? Each ancient people transformed their history into a myth. Myths became the foundation on which each culture was based. Now, this is the important part. Every aspect of an individual culture's world is a reaction to things passed down from generation to generation. It becomes the basis of society, including dietary customs. How many of you try and change people's diets? Morality, including food taboos. Again, we get into dietary choices and why people make them, and religious and political beliefs. So we've got all these layers of things. It's not enough to go in and say, oh, you have type 2 diabetes. That means you've got to stop eating this and you've got to start doing things this way. Simple, right? And you say, are you going to be compliant? Of course I am. Right, right. So, and then another thing is the concept of time. If any of you, and I know a lot of you have been in Central or South American countries or elsewhere, you know that time is in a different frame. I remember my first night in Guatemala City having dinner at 11 o'clock at night. Well, it was a little strange for me, but absolutely normal and the way everyone lived. And it was my fault that I didn't fit into it. I learned very quickly, though. So, and when we talk about time orientation, for the dominant Anglo culture in this country, it's a future orientation. We talk about prevention. We're talking about the future. We're trying to prevent disease in the future. A lot of cultures have an orientation in the present or in the past. You look at the Australian Aborigine people, and their culture is very much tied to the past, but it's the present. They have what they call the dream time, and those are the mythic times. But it's not a future orientation. So where does that put us when we talk about chronic disease and risk factors and the prevention of complications? If people aren't looking toward the future and thinking about the future, how are we going to convince them that they need to do something today because 15, 20 years down the road it's going to make a difference in their health or their lives? Now to us, that makes absolute sense, but to a lot of people it doesn't. And then we have something called the image of limited good. If you work with people who come from, say, a different cultural background, we have a friend named George Blue Spruce. George was the first Native American dentist. He was also an assistant surgeon general. He was an admiral in the Navy. George is a very interesting man. He founded something called the, let's see, I think it's called the American Indian Dental Society. There are very few people in it, but you have to be a full-blooded Native American to be part of this dental society. George now is in his 60s. He has a practice that, he has someone else in his practice now, so he spends most of his time going around the country talking to young Native American people, starting when they're in 4th and 5th grade. Because in the Navajo Society and some of the other Pueblo societies from which George comes, there is the theory of limited good, that everyone is supposed to be equal, and if anyone rises above another, whether it's in schoolwork or in the amount of money they have or the clothes they wear, they're looked down upon because they believe there's just so much good there for everyone. And if it's not shared equally, if someone has more than the others are going to suffer. Now, I'm talking about today. I'm not talking about 500 years ago. But these are the things that we see when we really listen to people and listen to what they're thinking about. George has been quite successful starting in the lower grades now, talking to young children and saying, you can do what you want to do. Of course, he'd like them to become dentists or physicians or nurses. He'd like them to be in the health field because, you know, as a lot of us believe, the people need to come from that culture to treat people within the culture because that's their heritage too. Remember one time Ruth and I were in, Ruth was at Crystal City or Cotulla in the public health clinic, and we had a young black female dentist from Chicago. Now, this was quite a culture change for her, and she was loving it because it was her first chance. We had a really good conversation with her. It was her first chance to see anything out of her own culture. And she was learning. I hope by this time she's learned Spanish. Imagine she has. But you see, we have these ideas of how people are, and we are plopped down into a new setting, and we think, gee, all these people are acting very strangely. And maybe it's our worldview of them. So the theory of limited good is very much alive and well today. Fatalism. What's fatalism? Any of you ever read Octavio Paz? I know Camille has. He wrote a book called The Labyrinth of Solitude, and the underlying feeling of this whole book is fatalism. Anything that happens is God's will. And unfortunately, with a lot of older people, I don't care what culture they come from, in order to cope with the world and their lack of material things, they cope with what's happening to them today by, well, if it happens, it's God's will. So where does that put us, again, when we're talking about disease and diagnosis and prevention? I read an article in the Santa Fe paper, the New Mexican, and it said, even though Hispanics in general have lower rates of cancer than Anglos, they are equally likely to die of their disease, because once their disease is diagnosed, for many, their health belief system is based in fatalism. They have it, and this unfortunately is why type 2 diabetes is so prevalent. My father had it, my grandmother had it, great Aunt Tilly had it, so it's just a family thing and I'm going to get it and I'll probably die from it. That's what fatalism means when someone is thinking about in the health field. So again, we have all of these things underlying it. I found an interesting article written by a physician who went in as a young practitioner into a black community in South Carolina. And he had no introduction to this community before, and he wrote the most wonderful article. It's a list of what you should do and what you shouldn't do. And he talks about a man who came in from the Sea Islands of Georgia, very remote, and he presented with pain in the feet and what he called falling out spells. Well, this was a whole new world to him. So he made up a list that says this is what a health provider should ask when he goes into a new community. What is the community's understanding of good health? Expectations. The physician has one expectation, or the practitioner, whatever the field, and the people that live there have another expectation. When is a member considered ill? Again, something that we think we know, and if you're ill, you need to be treated. Maybe that person is not considered ill in that community. What are the common causal explanations of illness in the community? Do they believe in the germ theory? Do they believe in hot and cold? Do they believe in all of these things that we know are part of different cultures? Do they really know what causes disease? Is this a community with tuberculosis? If it is, and they don't believe in bacteria and what bacteria can do, you've got a real teaching job ahead of you. And hopefully you've got some public health support. What are the usual modes of treatment, and what are the alternative health care systems available? Well, we know in South Texas that Curandismo is very much used, especially by the older population. And our school here has a wonderful relationship with the curanderos in the community and in South Texas. They come and they will talk to the medical students, and they will say that, you know, I know when I've reached my limit, I'm more or less doing the social things, but I'll refer the people that come to me into your system because I know when I have reached the limit of my expertise. So a lot of people have an alternate system that they're probably not going to tell you unless you know the community and unless you listen. Who is the medical decision maker in the family? How much is the patient responsible for illness, cure, or prevention? Who makes the medical decisions? At 1 o'clock, you're going to have an interesting presentation by Val Lawrence. And she's going, let's see, what's the title? Dancing Again After the Knife, Who Will and Who Won't. But I'm involved with Val in another study that she's doing on consent for mammography, and we're trying to put a tool together, and this is her project, I'm just a consultant, putting a tool together for both Anglo and Hispanic women, and how do you make the decisions whether to have a mammogram or not? How much does money play? What part does the cost play in it? How much does the husband makes the decisions on where the money will be spent? Are we going to spend that money on a mammogram? And if we're not future oriented, you know, is 15 or 20 years down the road, is that kind of thinking even part of what we do? So I think you're going to enjoy what Val has to say. What are the attitudes about death and dying? Now, the people that we'll be with for the next week or so have very different attitudes than we do. And healing to them isn't necessarily a medical healing. It's becoming in tune with whether it's nature or the culture or the people you may have heard at one time, coming to terms and coming to a balance. They call that healing. So, you know, again, we have all these terms and we know exactly what they mean. But maybe the people we're talking to, or talking with is a better term, don't know what they mean. So let's talk about the two words that I mentioned first, compliance. How many of you use the word compliance on a regular basis? Okay, and that's what most of us do. We expect people to be compliant. They come in, we say, oh, you have this, you need this, go home and do it. When they come back, did you do it? No, I didn't. Why not? You're non-compliant. So let's look at a definition, two definitions. From the Random House Dictionary of the English Language, compliance is the act of conforming, acquiescing, or yielding. A tendency to yield readily to others, especially in a weak or subservient way. Conformity or accordance. So what is usually the health professional-patient relationship? What is it? Is it, I know best? Okay. That's when we expect them to be compliant, to do as we say. Now looking at Tabor's medical dictionary, compliance, listen to what they say about compliance. The extent to which a patient's behavior coincides with medical advice. Compliance may be estimated by carefully questioning the patient and family members, evaluating the degree of clinical response to therapy, presence or absence of side effects of the drug used, and counting of pills, checking for drugs in the urine. All of this is compliance. Now, there is a much softer word, a much more comfortable word for me. Adherence, which is a mutually agreed upon course. Now let me read you the Random House Dictionary's definition of adherence. Fidelity or steady attachment, adherence to a mutually agreed upon course. This means you explain, you discuss, you get feedback from the person that you're working with, because if they don't agree with what you're proposing, they're not going to do it. It's just one of those things. Now that's adherence in a regular dictionary. I looked in 3 medical dictionaries for the term adherence, and this is the one that came up. It defines adherence only in the context of the stickiness of bacteria. Now, does that give us a clue? So, you see, we've got all these expectations. So, and now we get to an ethical issue. We explain to a patient or a client what the problem is. Give them all the test results. Tell them what all the side effects of the drugs are. And do they have a say in whether they're going to do this or not? Should they have a say in whether they accept treatment or not? How many think yes?
Well, I think they should.
How many think no? Aha, Ruth, you've done your work this year. Okay, but I know, but you know, you all came in, you wouldn't be here if you didn't have these feelings and want to do the best job. Now let's talk about ethical choice. In fact, I've got a physician wrote about the ethical issue of choice on the part of the patient. And this physician said, while a physician has a right and an obligation to provide information to patients in such a way that they can understand, it is the patient's right to choose and act on that information. For patients who do not wish to comply, it is inappropriate to attempt to change behavior. That's from a physician. And then another physician wrote from a little more of a cynical point of view based on the training that he had. And he's talking about elderly arthritics. Now, can you think of a more chronic disease, a more painful chronic disease? This man is a specialist in arthritis. Patient reluctance and fear of seeing a physician, lack of trust, fear of being intimidated and having their condition trivialized, communication difficulties, and follow-up frustrations are all problems with people with painful chronic disease. The physician said he voiced the lament of physicians everywhere and other health professionals who treat patients with chronic disease. It is a frustrating task, one for which their training in acute care and even their reasons for entering medicine have left them largely unprepared. And I think we're seeing an improvement in that now. Certainly courses like this give you different viewpoints and different things to look at. Let's see. All right. I mentioned health belief models. What do you do if you have a patient who comes in to see you and they've got risk factors for whatever, for a chronic disease, and you give them all the information, you talk about family history, but and if you give them, say, you have an 80% chance of developing this, are they going to see themselves necessarily in that 80%? Or are they going to see themselves in that 20%? What do you think? In the 20%. And I think that is when I ran across that, I thought, gee, that's not the way I look at things, but, you know, we all look at things differently. So, again, that's something that I hadn't thought of. In fact, there was a study of outpatients in a hospital that said most patients did not even possess the belief that they would ever develop what most of the other members of their family had. So how are you going to accept that as a healthcare provider? And that's a problem, is can you accept it? And will you accept it? Are you going to accept the patient's idea of what should be done? A real ethical question. Well, I think I've taken up all my time. I hope I've given you a couple of things to think about, maybe looked at things a little differently. And now, Ruth.
Anybody having any dilemmas they want to